Well, dear colleagues, there is many traps in attempt to present the results of treatment, the tumors of the sinonasal regions. There is many difference in this region. First, there is a difference according to the sites of origin. The most often origin of the tumors is maxilla, maxillary sinus, and the second place is nasal cavity. But in the great number of the cases, like in this, the cancer catch two compartments or three compartments, and in these cases it is very hard to say what is the true origin and how to present this cancer as the cancer of the maxilla or the cancer of the nasal cavity. Then the wave of spreading is also different. In the upper part of this region, the cancer spread toward the endocranium or orbit. In the lower part, it can spread toward the pterygomaxillar fossa or infratemporal fossa, or over the lymphatic vessels into the neck lymph nodes. Also, there is much of the differences, and if you compare the results, it is very hard to compare the different group. Then, the histological types is also different. There is a lot of the squamous cell carcinoma, about 80%, and the carcinoma. But another form of the tumors are really rare, and some of them I saw only once during my career. And the next is difference according to the size of tumor, and that is the most important. If you plan to resect the cancer, you will resect the different volume and make the reconstruction different kind of the space, and finally functional results is also a little bit different. According to the Serbian cancer registry, the cancer of this region is very rare. In the nasal cavity, we have 0.1 new cases every year, also in the maxillary sinus. And if we look at the incidence of the cancer in this region, incidence in the nasal cavities is 0.2 and in the maxilla 0.1. That means this cancer is rare, represent less than 10% of the head and neck cancer, and it is more often in the male. In elderly ages, and very rare in the patient less than 5 decades of the life, in the both groups. As you know, there is a 3 stadium in the development of the disease. First is asymptomatic, and this stadium is resembled to the chronic inflammation of this region, but unilateral signs of the symptoms with nasal obstruction, epistaxis, and bloody discharge from the nose. And if you have some of these symptoms, it is very important to think that maybe there is some malignant tumors. Then, when the tumor grows, he will first the empty space, but after that he will make the deformity of the bony structures, deformity of the face, and there is a symptoms of the deformity of the bony part, loss of the teeth, diplopia if they go to the orbit, proptosis, or go to the alveolar process with a problem in this region. And finally is the destructive process with the involvement of the endocranium, brain, or toward the orbit, and produce the problems with the vision or with great skin exudation. We know that the clinical exam is extremely important, and now every, I think, institution possesses the endoscope, which revealed early diagnosis of the tumor in this region, which is important for the plane of the kind of the intervention. After that is imaging diagnostic procedure, a very important improvement in this region, because with CT scan we can see the invasion of the bony part and destruction, but in some vague cases, like in that, when you can notice that there is something in the endocranium, you will take MRI, and on this way you have a complete impression about the volumen, about the structures which is involved in the spreading of this cancer. Biopsy is also important, but in some cases it is really extremely hard because the tumor pushed the soft tissue, mucosa, and sometimes the biopsy is false negative. That means we don't reach the area of the tumor, we reach the mucosa, normal mucosa. And what is important is to have good cooperation with the dentist, with the orthodontist, to ask them for the help before you start to perform some surgical intervention, because after we get the problem, it is hard to resolve that problem. For the better understanding of the tumor of this region, for the better understanding of the invaded tissue and how to plan the intervention, there is many classification. Many classification has been proposed in the last centuries. First, as you know, is Ongrin, who classified this tumor on two parts, anterior, inferior, which is more benign, and posterior tumors, which is really aggressive because it can spread over the orbit or endocrinium. Then is Lederman classification on 3 stages, supra stage, middle stage, infra stage. He used the lines of dividing this middle face region according to Sebila, and we now use, of course, TNM classification, 8th edition, which separate the maxillary sinus tumor and the nasal cavity tumors in the 4th stage, from T1 to T4, according to that which structures are invaded or infiltrate. Basic for the treatment of the tumor of this region is the surgery. In the greatest number of the cases, it is the open surgery, but I know that now we have a lot of the centers which used or performed the endoscopic surgery, and I think it becomes more popular everywhere, but still in our hospital, and we are able to resolve some small cancers, more cancer in small region with endoscopic surgery. Radiotherapy is adjuvant therapy and other kind of the well-known treatment. Sorry, it goes very quickly and fast. Other kind of the treatment is, what is that? I'm going back, sorry. Is adjuvant therapy, chemotherapy and biotherapy is for the advanced stage, for the recurrences and another situation. Endoscopy is now very well in usage for the small resection, as I said, for the combination with the open surgery to debulk the tumor and to help the surgeon to find the origin of the tumor and remove some bony parts, and of course to restore if there is communication, especially toward the endocrinium, and to protect from the leakage. Also, there is many classification of the maxillectomy in the past. You know that the first was performed by the Dipitren in 1820. After that, it was done sporadically, but now there is a lot of this kind of the surgery, and I think that the most familiar is the classification by Brown, who classified these tumors on the 4 types. According to the vertical components, first is the limited maxillectomy, that means resection of the one wall of the maxilla. This kind of the resection in some patients not need to perform some reconstruction, some prosthetic device. Type 2 is subtotal maxillectomy, that means 2 walls is resected and there is a communication with 2 space. It should be reconstruct. Total maxillectomy with enucleation, not exenteration of the orbit, is a classical operation, and type 4 is the orbitomaxillectomy, which is really big operation. And there is, I don't know what happened. Maybe I breathe and remove the picture. No, flex, okay. And subtypes is according to wide of the resection of the hard palate. You know that reconstruction to 1919 based on the different prosthetic device, and we are very familiar with that and have a good experience with our orthodont, who with this device separate the oral cavity with the nasal cavity and re-establish the very important chewing function, or aesthetic results with the patient with orbitomaxillectomy. But after 1919, there is a lot of the reconstructive surgery in this region, flap surgery, with general rule that first is important to reconstruct the bony part, then soft tissue, and it is possible to put some dentist prosthesis or dentist implant in this region and restore completely chewing function. Of course, these flaps have the disadvantage because if the flap have the petiolus less than 10 centimeters, it cannot reach the blood vessels in the neck, and it is very hard to connect them, and you need to put the vein graft. With this kind of intervention, the functional and aesthetic results become much better. About the metastatic process in the neck lymph nodes, we know that this region is really poor with the lymphatic network, and that in the Homan studies with 96% of the N+ neck, always the level which is involved in the metastatic process is level 1 and 2. That means upper jugular and submandibular lymph nodes. Other, such as retropharyngeal and parapharyngeal, in the advanced cancer in the group 3 and 4. We know that the most often histological type who make the metastasis is squamous cell carcinoma. Other types are rare. And according to the guidelines, in N0 it is not necessary to perform some elective neck dissection, but new recommendation is in the cancer more than 4 centimeters in size, in volume, it is recommended to make the elective irradiation. And of course, different kind of the neck dissection if the neck is plus positive. But what is the general view of this cancer is that there is a lot of the recurrences, up to 70% is overall recurrences. That's because it is very hard to make the radical resection of the cancer in this region, and you always have the positive margin. And because of that, local recurrences comes up to 70%, and only 20% of them is possible to operate. In the neck, you have up to 30% of the recurrences, but more than 50% is possible to operate. And if you look at the literature, there is a great series of the patients. In this region, great series means 100 patients or closely to this number, and there is a great number of the local recurrences. For example, in the group of 116, it's 68%. When we look at the neck, the number of the recurrences or percentage is about 20 to 40%. And the survival rate is low in the squamous cell carcinoma, about 30%. But if you look at other types, for example, adenoid cystic carcinoma, it is about 60%. And finally, to present the results with our patient, it was the 56 patients which I summarized during the 10 years period. You can see that the most often sites of origin is maxilla, then nasal cavity, but in 30% it is very hard to say is it the tumor originated from the maxilla or the nasal cavity. Also, we did the TNM classification of this tumor. The most often was a squamous cell carcinoma, about 50%, 53. And a lot of the patient was in advanced stage of the disease, 62%, but only 4 had a neck positive of all of them. We performed in 47 surgery, open surgery 42, and in 5 endoscopic surgery. The most often it was the total maxillectomy, in 7 orbital maxillectomy, and the results of treatment are that overall survival of all operated patients, 5 years is 38%, but surprisingly in squamous cell carcinoma we had a good result, 62% of the patients. Other histological types was not so successful. And the conclusion is that the malignant tumor of the sinonasal region continued to be the diagnostic and therapeutic problems. Early diagnosis, endoscopic examination of the patients with the disorders of this region give a great chance of early detection of the malignancy. Better imaging diagnostics, either CT alone or in combination with MRI, improves the local assessment of the tumor expansion and thus a better treatment plan that affects survival of the patient. And the surgical treatment, endoscopic or open surgery, is still the basic approach in the treatment of malignancy in this region. And thank you for your attention.